Thanks for holding on. My wife was drying her hair and the noise was driving me crazy. So, but anyway, the paper I wanted to review today looks at a different type of drug mechanism for a potential drug to treat a cardiovascular disease called pulmonary hypertension. Pulmonary hypertension is a disease in which there is a increase in mean arterial blood pressure of the pulmonary arteries. As you may recall, the mean arterial pressure in the systemic circulation is roughly about 100 millimeters of mercury. In the pulmonary circulation, it's more like around 13, 14. So it's a much lower pressure system than there is in the systemic circulation. And the rationale for that, the reason for that, is that on the pulmonary side, you want, of course, to have gas exchange in the level of the alveoli, and in blood flow, in terms of diffusion, there's a balance between hydrostatic pressure that tends to push fluid from the blood vessel into the surrounding tissues, right? And that is opposed by an oncotic pressure that wants to pull or keep fluid in the blood. Thus, as from the standpoint of the alveoli, keep the alveoli relatively dry, so that way there can be an efficient diffusion of gases through the alveolar membrane. So, if pulmonary pressure increases, it can do a couple of things pathologically. One, it can increase the hydrostatic pressure, and so alveoli will tend to fill with fluid. And you can see that in instances such as congestive heart failure, where blood backs up in the pulmonary vasculature, and fluid leaks out into the lungs, and the person can essentially drown. Pulmonary hypertension, though, can come from other causes. Some of it is idiopathic. They don't know why. Some of it can be congenital, and some of it can be related to, ultimately, systemic hypertension. The problem with pulmonary hypertension is twofold. One, it decreases blood flow to the lungs, so that decreases gas exchange, so it leads to hypoxia. Secondly, increased pulmonary artery pressure chronically can damage the right ventricle of the heart, leading to right-sided heart failure. Ultimately, pulmonary hypertension is a fatal disease. With more recent treatments, mean survival rates maybe a little more than 5 years. Not a long time. There is no cure. Almost everyone dies from it within a 5-year period. So it's not like what you see with systemic hypertension, where people can live for decades with systemic hypertension. Pulmonary hypertension is a very different disease in that way. The incidence of pulmonary hypertension runs about 1% of the population. Apparently, it's more common in women between the ages of, I think it's 40 and 70, although sometimes it can be congenital, so some children are born with it. So I have a figure to show you a little bit of what it looks like. So hold on here just a moment. I'll do a share. Actually, I need to get the recording going.
Recording in progress.
There we go. Okay. So let me do a share. We'll see what I can show. Okay. So this figure just shows pulmonary hypertension, and the key here is in the pulmonary arteries is a narrowing of the lumen of the pulmonary artery, and that narrowing then results in restricting blood flow. And just like with any other artery or blood vessel, if you narrow the artery, you increase peripheral resistance, which then increases pressure in the artery. This narrowing can have two causes. One is constriction of the smooth muscle. Blood vessels have essentially three layers. There's an inner layer of cells referred to as the endothelial layer. The middle layer is made up of vascular smooth muscle cells, and then the outer layer is made up of connective tissue. And so over time, there is a pathological remodeling of the pulmonary arteries, resulting in a thickening of the muscle layer and the connective tissue layer. And that thickening of the wall then decreases the diameter of the lumen, so there is less blood flow. Does anyone have any questions about this overview of what pulmonary hypertension is? Okay. Well, given that most of the available treatments for pulmonary hypertension now relate to a couple of things. One is dilating the pulmonary arteries by relaxing the smooth muscle. And so an example of a common drug that's used to treat pulmonary hypertension is sildenafil. Does anyone know the brand name of sildenafil? It's a fairly famous drug over the last 10 to 20 years. That's Viagra. And the way Viagra works is it inhibits the metabolism of nitric oxide. Nitric oxide is an endogenous vasodilator released by the endothelial cells. Nitric oxide is a gas that then diffuses to the smooth muscle cells and relaxes the smooth muscle cells. Commonly, sildenafil, aside from being used to treat pulmonary hypertension, is also used to treat erectile dysfunction in men. And it works the same way from the standpoint of being a vasodilator. Another approach is to give drugs that are antagonists, once again, of a local autocord called endothelin. Endothelin is a peptide that is synthesized and released by endothelial cells that has the opposite effect. That is, what it does is it constricts smooth muscle cells, vascular smooth muscle cells, resulting in vasoconstriction. So you can imagine that if the two approaches are related to either inhibiting the metabolism of nitric oxide. So you increase its concentration and dilate blood vessels, which, by the way, the second messenger there is cyclic GMP. So nitric oxide increases the release or activity of the production of cyclic GMP by stimulating guanylyl cyclase. And sildenafil inhibits the breakdown of nitric oxide, which is mediated by a phosphodiesterase. No, what it does is it inhibits the breakdown of cyclic GMP by, I'm trying to remember the name of the enzyme. It's a phosphodiesterase, so it inhibits the breakdown of cyclic GMP. So what we're going to be talking about today is a different drug mechanism or potential drug mechanism, which is the role of sulfur dioxide. Let me go to the paper. Hold on just a moment. Here we go. Okay. The reason I selected this paper is because just in terms of drug mechanisms, there are drug mechanisms that work through these gases. So we're not talking about neurotransmitters that are liquids or things released by nerves, by nerve terminals, or other kinds of dissolved solids. Sulfur dioxide is a gas that is highly diffusible and can affect signaling mechanisms that then can lead to several things. One is contraction of smooth muscle cells, but beyond that, it can affect signaling cascades that are involved in the proliferation of smooth muscle cells and the adventitia, which then results in the change in the structure of the pulmonary artery itself. So the hypothesis here, and this is something that is just cutting edge now and is something that's ongoing research, is if there is, if it's possible to develop a drug which can deliver sulfur dioxide or be a precursor for sulfur dioxide, then what can happen is these drugs can interrupt or at least hinder the remodeling of the pulmonary artery, and so at a minimum prolong life, if not cure the disorder. Now, what I would like to do is use sulfur dioxide as an example of a class of transduction molecules, signal transduction molecules, of which are gases. The one that is probably best known is uh, nitric oxide, right? Um, can anyone name for me a drug which has been available since at least the 1800s that works as essentially a precursor to nitric oxide?
Is it nitroglycerin?
Exactly so. So nitroglycerin is through a metabolic process increases the concentration of nitric oxide, which then will dilate blood vessels generally, both arteries and I believe veins. And the result then is a relief of angina, that is chest pain. What do you think is the mechanism for the relief of the angina? I'm just trying to get an understanding of what your familiarity is with cardiovascular drugs.
So
What,
it's
go ahead.
basically causes vasodilation and
Right.
decreases the venous return.
Yes. So,
So it decreases the load on the heart.
right. So, very good. You're everything you're saying is correct.
Yeah.
What's
So
the next step?
there is less oxygen consumption. The
That's
demand
right.
decreases.
Oxygen demand goes down,
Yeah.
and chest pain comes from, or angina comes from, an imbalance between oxygen demand and oxygen supply.
Yeah.
So if a drug can decrease oxygen demand by decreasing the workload of the heart, by decreasing venous return, and also decreasing arterial blood pressure, oxygen demand will decrease both and come in a balance with the available oxygen supply, which of course is becoming, to the heart muscle, is becoming restricted because of atherosclerosis of the coronary arteries. So that's what's happening here. In this paper, we're not looking at nitric oxide, we're looking at sulfur dioxide. And the paper talks about the synthetic pathway for sulfur dioxide. And you could see that, at least in the beginning, this is a rather busy figure. You have the amino acid, sulfur-containing amino acid, L-cysteine, which then goes through several either enzymatic, this AAT, does anyone know what that acronym stands for? That's acetic acid, no, not acetic acid, aspartic acid transaminase, okay, which then converts, well, this intermediate to beta-sulfonyl pyruvate, which then non-enzymatically generates sulfur dioxide. And then sulfur dioxide then can also have some further metabolic changes to ultimately leading to sulfate. Okay, so that's one synthetic pathway. You notice here that, just want to point out that nitric oxide that we've just been talking about inhibits the action of aspartic acid transaminase. So it's interesting that as nitric oxide goes up, the vasodilator, that will decrease sulfur dioxide. Hydrogen sulfide, on the other hand, also through NADPH rearrangement will also produce sulfur dioxide. Thiosulfate can also generate sulfur dioxide. And glutathione persulfide, which is generated from hydrogen sulfide, can also produce these products of sulfur dioxide, leading to sulfate, which I believe is the active component. Sulfur dioxide, well, actually, I'm not sure if the sulfate is actually active or just the metabolite. Did anyone see that in the paper? Which is the active molecule? Is it the sulfur dioxide itself, or is it the sulfate? What do you think? Well, we'll get there. My suspicion is it's the sulfur dioxide, but I'm not sure. So if we go farther down, they show in this review that sulfur dioxide is generated in the endothelial cells and the smooth muscle cells, at least, as well as the surrounding connective tissue. And then in the synthetic pathways, they go through all these different pathways that are essentially described in the figure. Here's this reference to nitric oxide inhibiting aspartic acid transaminase. Okay. And then catabolic pathways. So another feature of both nitric oxide and sulfur dioxide, what's the half-life? Is it long or short? It's relatively short half-life in both of those gases. Which allows for relatively tight control. So the enzymes are found in endothelial cells and smooth muscle cells. So that indicates then that these cell types can synthesize sulfur dioxide. Perivascular adipocytes, which tend to surround the pulmonary blood vessels. MCs are mast cells that can also be involved in vascular constriction or dilation, and then also macrophages. These gases are commonly referred to as gasotransmitters. And I like this figure, which is a good summary figure. The key here, the key enzyme for the synthesis of sulfur dioxide is this ATT, the aspartic acid transaminase. And these mediators, like NF-kappa B and MAP kinase, and I think this is TGF, that is, looking at the legend here, is that tissue growth factor?
Transforming growth.
Transforming growth factor, thank you. Are all involved. All of these signal transduction pathways are up in this remodeling of the pulmonary arteries, and you can see the thickening of the wall, which then decreases the diameter of the lumen compared with normal arterial arteries. And then you have these other molecules, such as antioxidants, that can facilitate the activity of the ATT producing sulfur dioxide, which then can relieve some of the symptoms.
Dr. Johnson?
Yes.
So looking at the pink box, like all the pink boxes, where you have increase in NF-kappa B, then the Wnt pathway, and the ET1, looks like the disease is more, this disorder is more inflammatory and regenerative.
Right, that's exactly correct. So if you look at these boxes, these red boxes to the right, you could see the effect of these is to cause inflammation, endothelial cell inflammation, which then can disrupt function, smooth muscle cell proliferation, which you were just referencing, synthesis of collagen in the smooth muscle cells, I mean just thickening that middle layer, and then fibroblasts and collagen. All of these then are thickening the wall, which then, this is all pulmonary vascular remodeling, that's PVR for the acronym, that then results in pulmonary hypertension. Now, I'm hoping you guys have had a chance to review this paper. What does sulfur dioxide do with these essentially signal transduction pathways that then mediate all of these pathological effects? To move down here in the paper, one, what the paper reviews are a number of different experiments that show that there is an inverse relationship between sulfur dioxide and pulmonary artery pressure. In this section that's highlighted, children with left to right shunt CHDs, congenital heart disease, measured levels of sulfite in the control, congenital heart disease without pulmonary hypertension, with mild pulmonary hypertension and moderate to severe hypertension, and they found that these levels of sulfite are highest. So this is a metabolite in, or the pressure was, the concentrations were higher in those with the least symptomatic cases, and then lowest in those with the highest. So these values were equated to serum concentrations of sulfur dioxide, which ranged from 0 to 9.5. What they're looking at here is this metabolite, and then inferring from the metabolite what the concentration of sulfur dioxide or sulfite is. Persons showed a negative correlation between sulfur dioxide level and pulmonary arterial pressure. What's the implication of this sentence? A negative correlation between sulfur dioxide level and pulmonary arterial hypertension.
So increase in sulfur dioxide levels was indirectly proportional to the pulmonary arterial pressure. So,
yeah, so it's inversely proportional.
Yeah.
So that means as sulfur dioxide goes up, pulmonary arterial pressure is reduced. And they summarize this with, these results suggest a decrease in endogenous sulfur dioxide levels in children with congenital heart disease, pulmonary hypertension, and the degree of sulfur dioxide downregulation may reflect the severity of pulmonary hypertension. By the way, in farther up in the paper, they talk about this, the pathology of the congenital heart disease, pulmonary hypertension. Did anyone remember what that was in the paper?
The ductus arteriosus dysfunction, maybe.
That's exactly correct. So what is ductus arteriosus?
It's the blood vessel that sends blood away from lungs when the baby is in the womb, but when it is born, it closes up within 2 or 3 days, and then normal lung function and heart function begins. But in some newborn, the canal does not closes, so the blood don't flow to the lungs. It again flows back into the heart. I mean, I don't know the details, but I remember this.
Right. Well, you're right. That's correct. What happens in what's called patent ductus arteriosus, there's this shunt between the right ventricle and the left ventricle, which essentially bypasses the pulmonary circulation, because pulmonary respiration in utero doesn't really happen, right? And so in some infants who were born, as was described, that shunt, that duct closes, so that way blood is forced from the right ventricle through the pulmonary circulation, and you could have gas exchange. However, in some infants, that shunt doesn't close. Commonly, does anyone commonly know what they use to treat patent ductus arteriosus in newborns?
I think there are surgeries where they put a block on that shunt.
Mm-hmm. So
I don't know any pharmacological intervention.
Yeah, you could do it surgically, but another thing from a pharmacological standpoint is...
Indomethacin.
Say again?
Indomethacin.
Indomethacin. That's absolutely correct. And what does indomethacin have to do with closing that duct? What is indomethacin as a medication?
It's an NSAID.
It's an NSAID. And what's the mechanism of action of NSAIDs?
So they decrease the production of prostaglandins.
Prostaglandins. You're exactly right. And so in utero, it is prostaglandins that maintain the patency of that duct. And so if the duct does not close after birth, one treatment is to give indomethacin that blocks the synthesis of the prostaglandins that maintain the opening of the duct. This is a little bit off topic, but it is what it is. Now, in congenital defect, where for some anatomical reason it will not close, remember, right side of the heart is low pressure, left side of the heart is high pressure. You have this, left side is high pressure, right side is low pressure. Which direction is the blood going to go through the shunt?
What's the location?
It's going to go from left to right. And if it goes to the right side, what's going to happen to pulmonary artery pressure?
Increase.
It's going to go up, which then will result. That's one cause of this pulmonary arterial hypertension. Okay, so then this review paper goes through or reviews a number of experimental models of pulmonary hypertension. Can anyone describe for me what those models are? Well, here's one. Hypoxia induced can cause pulmonary hypertension. Pathologically, this can be caused by COPD. That's an acronym for what?
Chronic obstructive pulmonary diseases.
Exactly so. And that is a pathological scarring of the lung tissue, which then results in an increase in arterial pressure. It says here, hypoxia is the most significant pathogenic factor contributing to pulmonary vessel R's remodeling and the development of pulmonary hypertension. So, they induced a rat model of pulmonary hypertension using hypoxia. And they found that exogenous SO2, what do they mean by that? What is exogenous?
So give an example.
Yeah, it's actually administered, so it's not synthesized endogenously. And they found that that could suppress the elevation in mean, the small m, there's mean pulmonary arterial pressure caused by hypoxia, and improve the changes to the relative thickness of the muscle arteries and the ultrastructure of PAECs, are pulmonary artery endothelial cells and smooth muscle cells. So this can have sort of a positive impact in delaying the remodeling of the pulmonary artery. And they're pointing at the molecular mechanisms involved in the inflammation. Are these one, I'm not certain what the ICAM1 is, but once again, we have the NF-kappa B signaling pathway in the endothelial cells. And then the cell nuclear antigen and MAP kinase with the RAF-MEK-ERK pathway. And once again, the pulmonary artery smooth muscle cells and the endothelin ET1 peptide. All of these seem to be involved in regulating this cell wall. The administration of exogenous sulfur dioxide mitigated the aforementioned hypoxia-induced molecular changes, which were consistent with the findings. So apparently, the hypoxia affects these signaling pathways that then results in the proliferation of endothelial smooth muscle cells and actually adventitial cells as well. So what the authors did, they enhanced endogenous sulfur dioxide in endothelial cells. Results showed that similar to the effects with exogenous endogenous sulfur dioxide suppress the expression of these inflammatory pathways. Our findings demonstrated that NF-kappa B signaling mediated the inhibitory effects of sulfur dioxide on the abnormal inflammatory response in the development of hypoxia. Well, earlier on in the paper, it sort of suggests that the NF-kB signaling pathway promoted these pathological changes, and this sort of suggests that the NF-kappa B signaling pathway mediated the inhibitory effect of sulfur dioxide. So my question is, in your reading of the paper, which is it? Is NF-kB good or bad? Because, I mean, if we move back up here, we see this signaling pathway increased in pulmonary hypertension. But is this just in response to, or does it stimulate? What do you think in your readings of the paper? Let's go down here a little bit. Or maybe it's farther up. So you guys feel free to help me out here so I get this right.
So I found, I just found this line. It says that the NF-kappa B signaling pathway mediated the inhibitory effect of SO2 on the abnormal inflammatory response.
So the NF-kappa B inhibits the effect of SO2?
Yeah.
Which means then that an increase in the NF-kB then would tend to promote, the remodeling of the artery or decrease?
Yeah.
Okay.
Yeah, would induce inflammation.
Okay.
So Dr. Johnson,
Yes.
during, I'm coming from the viral infections background. So during viral infections as well, it is the NF-kappa B pathway that is stimulated. Like that's the first innate immune response that we see.
And does that lead to inflammation?
Yes, and that causes like trafficking of different innate immune cells like the monocytes, macrophages, and the NK cells, NK cells, around the endothelium of the blood vessels. So that is more damaging, I believe. NF-kappa B should be more damaging than
Right, protective, right. So what I'm understanding here, and especially from what you're saying, Vivek, is that NF-kappa B is involved in the inflammatory process, correct?
Yes. In
Okay.
fact, it should be the first line of defense, like in any inflammatory response.
Right. Okay.
And Dr. Johnson,
Yeah.
here, like when you, if I believe there is a relation between ICAM1 and NF-kappa B. So
Mm-hmm.
ICAM1 is intercellular adhesion molecule. So this is basically responsible for the chemotactic
Oh,
movement of the different immune cells from systemic circulation to the site of damage.
like macrophage, monocytes,
Right,
leukocytes more broadly.
right.
I highlighted this sentence. The molecular mechanisms involved in pulmonary artery remodeling include ICAM1, NF-kappa B, proliferating cell nuclear antigens and MAP kinase signaling pathways, endothelin T1, and collagen metabolism. And they conclude here the administration of exogenous sulfur dioxide donor mitigated the aforementioned hypoxia-induced molecular changes. Okay. And here it shows endogenous sulfur dioxide generated by pulmonary artery endothelial cells suppressed the expression of ICAM, an inflammation-related factor in mice with hypoxia-induced PAH. Therefore, they say, our findings demonstrated that NF-kB, kappa B signaling pathway mediated the inhibitory effect of sulfur dioxide on abnormal inflammatory response in the development of hypoxia-induced remodeling and pulmonary hypertension. I'm wondering if that was a poorly written sentence. Does sulfur dioxide inhibit NF-kappa B? Or does NF-kappa B inhibit sulfur dioxide? Mediated the inhibitory. This sentence suggests that NF-kappa B mediates the inhibitory effect of sulfur dioxide.
Sir,
And then they're looking at this WNT, this Wnt signaling pathway. Okay, so apparently this NF-kappa B is signaling pathway is one of the key pathways in the regulation of cellular processes, including proliferation, inflammation, differentiation, and apoptosis. Sulfur dioxide suppresses all of these things. blockade of the NF-kappa B signaling pathway abolished the effect of SO2 reduction on the overexpression of this other feature. So this suggests that NF-kappa B works against sulfur dioxide. Is that how you're reading it? Okay. These findings suggest that the inhibitory effects of sulfur dioxide on smooth muscle cell proliferation, migration, and collagen metabolism were associated with this pathway and NF-kappa B, although once again, it's NF-kappa B is involved, but NF-kappa B suppresses sulfur dioxide. Is that how we understand this?
So, Dr. Johnson, I think they are considering NF-kappa B as the umbrella pathway, and like if the NF-kappa B pathway kind of is activated, sulfur dioxide may not be that effective. Maybe.
Right. Okay. Well, maybe this is the bottom line. Normally, in normal tissue, the sulfur dioxide acts to keep the balance in these various pathways related to the proliferation of smooth muscle cells, etc. But in pulmonary hypertension, there's activation of the NF-kappa B signaling pathway that suppresses the normal function of the SO2, which then results in this remodeling. And the implication of that is if SO2 can be supplemented, then that would tend to decrease all this remodeling activity. Does that make sense? What do you think?
So, Dr. Johnson, I have a question.
Sure.
So, if nitric oxide kind of inhibits sulfur dioxide, then why do we kind of in the first place give nitric oxide to pulmonary hypertension patients? Because we are kind of with nitric oxide we are just getting the vasodilation effect, but with sulfur dioxide we are actually targeting the key cause of pulmonary hypertension, like remodeling and the other inflammatory responses.
I think that's an excellent point. And I'm wondering, the beneficial effect of nitric oxide as a vasodilator was understood first. And patients that were administered things like sildenafil or nitroglycerin saw a therapeutic benefit symptomatically in the short term, but they were unaware at that point that by suppressing sulfur dioxide in the long term, they're promoting the remodeling. So as I sort of mentioned at the beginning, pulmonary hypertension is a fatal disease with a survival rate of these days, a little over 5 years. And so when someone first becomes symptomatic, they'll give these drugs that relieve the symptoms, but that could actually, in the long run, maybe be shortening the life expectancy of the patient.
Sir, I have a question regarding this.
Yeah.
So there are patients of angina and other diseases in which organic nitrates like nitroglycerin are continuously used.
Hmm.
So, do they end up having pulmonary hypertension?
The incidence of pulmonary hypertension is about 1%. So, in the realm of things, what's the incidence of pulmonary hypertension in a million people? So, what's 1% of a million? It's 10,000, isn't it?
Yeah.
In the US, there's like 340 million. So we're talking about maybe 1 million people or 3 million people. In China, which has what, roughly about 1 billion people. So that's 10 million people. Would you say that's rare or common? In the realm of things. By the way, what's the mortality rate associated with cardiovascular disease? It's probably more than 50%, or roughly 50%. So you're talking about 1 as compared to 50. It's rarer than cardiovascular disease, which includes heart failure. So it's a smaller group, but I mean, it's still a large number of people. I'll share this with you on a personal note. My father, when he was about 80, was diagnosed with pulmonary hypertension, and he lived for about 5 years. And he died from complications from pulmonary hypertension, but the symptoms are very, very bad in terms of limitations on his activity, hypoxia. Hypoxia, by the way, tends to automatically generate anxiety. So he suffered from anxiety. He suffered from hypoxia. For a while, he was using a nasal cannula to deliver extra oxygen. It was just a miserable existence before he died. That, in part, is what made me interested in this paper, so I confess. But I mean, it's I think that this is sort of cutting edge in terms of understanding drug mechanisms and what they can do. So once again, they showed in this other MCT model of pulmonary hypertension, if we go back up to the beginning here, this MCT, which is monocrotaline, inhibits sulfur dioxide. And inhibiting sulfur dioxide, you indirectly inhibit aspartic acid transaminase, which then decreases sulfur dioxide. So if we move back down here, sulfur, by increasing sulfur dioxide, there is an inhibition of the remodeling in pulmonary hypertension. This highlight further investigations using cultured fibrocytes stimulated by TGF beta 1 shed light on the mechanisms underlying the effects of transaminase, this aspartic acid transaminase overexpression, promoting increased endogenous sulfur dioxide and preventing the activation of what is that? Tumor growth factor or tissue growth factor?
Transforming growth factor.
Thank you. Signaling pathway, as well as abnormal collagen synthesis in pulmonary artery fibroblasts. So this is the bottom line from the standpoint of drug development. What they're looking to do in the future is developing a way of delivering exogenous sulfur dioxide to patients with pulmonary hypertension. And one of the proposals they're looking at, because sulfur dioxide by itself is just really obnoxious. It smells bad. It's, you just can't put it in a nasal cannula and have patients inhale it. But what they're looking at is what they make this statement: supplementation of sulfur dioxide or monocrotaline mediated models. Sulfur dioxide inhibited remodeling by attenuating inflammation, proliferation, and collagen dysregulation. And then in the long term, preventing the development of pulmonary hypertension. Previous clinical treatments, as we've been discussing, focused on excessive vasoconstriction. So they give vasodilators. However, these drugs give some symptomatic release. Few assessments of therapeutic effects. I mean, on clinical pulmonary hypertensions, given the pungent odor of sulfur dioxide. Have any of you ever smelled sulfur dioxide? What does that smell like? Have any of you ever smelled a rotten egg?
I don't know.
Yes.
Yeah, unpleasant. Most commonly used is a mixture of sulfite and what is hydrogen sulfite and is that sulfate, SO3 2 minus? Is that sulfite or sulfate?
Right.
So what they're looking at essentially here are prodrugs, that the patient takes the drug as a precursor. So that's like giving nitroglycerin that can stimulate the slow release of endogenous SO2 in vivo. And then they're also talking about binding these prodrugs to lipid nanoparticles that then can be targeted directly to the lung using a particular antibodies on the surface of the nanoparticle that will target the lung tissue, which then can enhance the specificity and stability of the sulfur dioxide, which then can target the pulmonary artery. So I think that's sort of the future of this. And if they can do that, what's your expectation from the standpoint of pulmonary hypertension? They're being very optimistic here. They're saying whoops. That's the goal. Inhibit or reverse pulmonary vessel remodeling. Reverse? What do you think? Do you think it can be reversed or just maybe stopping the progression? Is he being a little overly optimistic?
Yeah.
Yes.
Now, why would he be so optimistic? I'm talking about motivation here.
Maybe because there's still no fear for it, so they're really pushing for it. I maybe it's going to be a motivation.
I'm not sure I quite understand you, but my suspicion is, and it's just a suspicion, is he's a researcher in this area. And does he want more funding? Yes.
Maybe.
Right? So with this optimistic outlook, he's looking at, send me money so I could develop this, and we can cure all the world's ails, especially from the standpoint of pulmonary hypertension. Could this potentially reverse the remodeling?
No.
Maybe not, but it may slow the progression of the remodeling. The other thing is, do you think a patient who, let's say hypothetically, has access to this precursor for SO2, do you think they could go on it for a week and then they're done? No, they'll be on this for the rest of their lives. And what does that mean from the standpoint, looking at this purely from a capitalistic perspective? Is this dinero or money for drug companies? Yeah. Now, in terms of pure financial stuff, on the one hand, if this is a relatively rare disease, 1%, drug companies may not be so interested. But compared with, let's say, type 2 diabetes drugs. But if someone, once they have this, is on it for the rest of their lives, and these drugs can prolong survival beyond 6-7 years, maybe 20 years, hopefully, then there's some money to be made. But that's getting ahead of ourselves. In the beginning, I suspect the author here is being so optimistic because he wants to continue his research in the area. And so you always want to put a rosy potential outlook on the research that you're doing because it makes it more important. Any questions, other questions about this review?
So, Dr. Johnson,
Yes.
if like there are Wnt inhibitors available, in study actually, and they are used for to prevent proliferation in cancers.
Okay.
They're in clinical studies, but not in they're not on the market.
Mm-hmm.
And so I was wondering, if remodeling is the central, if remodeling is central to this disease, we can also try Wnt inhibitors instead of because I believe for sulfur dioxide it would be more of a formulation challenge than developing a small molecule inhibitor.
Right. I tend to agree with you. The other thing I think that they haven't really gone very far, because this is, this is still, for the most part, in vitro or preclinical, right? So they haven't done any clinical testing.
Right.
Where in your small molecule that you described, that's probably clinical at this point, is it? Or is it preclinical?
Yes. So we have both, Wnt promoters and Wnt inhibitors both. Promoters they use for liver transplant, where they want to buy some time before liver transplantation can happen. So they want to regenerate liver using Wnt. And then there are Wnt inhibitors as well, where which is used for tumor cell suppression.
Well, here's a question, and this is a concern that with these drugs that directly attack transduction pathways as opposed to binding to receptors, and this is a question for all of you. What's the likelihood of having a loss of selectivity, resulting then in an increase of adverse reactions? Because let's say the Wnt pathway or the other pathways that we've been talking about, they're used in other systems than pulmonary artery tissues, right? And so if we were to administer a SO2 precursor that's doing all of these things to all of these signal transduction pathways, what else is going to be affected? So what do you think? You know, I know that Dr. Kavanaugh has been heavily involved in research looking at signal transduction cascades, especially the MAP kinase cascade. What about adverse effects because of a loss of selectivity? What do you think?
So it's a high chance.
Say again?
So it's a high chance that there will be more adverse effect using like targeting these transduction pathways.
Well, I guess the response of this group, though, to that concern is the use of targeted nanoparticles that deliver the drug to a selected tissue. SO2 has a really short half-life. So if you're targeting pulmonary arteries, you may not necessarily be affecting signal transduction in other tissues where I'm just, you know, being sort of like an old-fashioned pharmacologist who's much more comfortable with drugs that target receptors, which by their nature are selective. Going with these approaches to signal transduction pathways that may be broadly utilized in all kinds of systems just makes me feel uncomfortable. But if you could tie that to a drug delivery approach, which can target a particular tissue, I'd feel more comfortable with it. You see what I mean? As opposed to just putting a gas mask and gassing someone with sulfur dioxide. I don't think that's such a hot idea.
But Dr. Johnson, even if they they succeed in developing a formulation that targets only the lungs,
right?
The paper also agrees that they have a metabolite in the form of sulfate, which is excreted in the urine.
Right.
I was wondering what would happen to renal function, like if there is excess sulfate excretion in the urine, because sulfate, I believe, is not the natural endogenous ion that is released in the urine.
Right. Well, you're right. They did reference that in the paper. And they referenced it within the context of that is how the body maintains appropriate sulfur concentrations. Is that right? Broadly speaking, across the body, because there's, sulfur donating amino acids all over the place. And there needs to be a way for maintaining homeostasis with sulfur balance. And you're right, the paper cites the kidneys, and then you raise, I think, a legitimate question.
Right. And another thing is on the very first, in the very first page where we saw that graphical representation of sulfur dioxide metabolism. I also noticed sulfur dioxide metabolism is causing pyruvic acid release, which again can participate in lipid synthesis. And I'm not sure, like, if that causes some of the lipid disorders, because if you see from beta sulfonyl pyruvic acid to sulfur dioxide, you have free pyruvic acid releasing. And
pyruvate, right?
But yes,
right.
And it is pyruvic acid is a natural like intermediate of the TCA cycle, tricarboxylic acid cycle.
That's right.
Then ultimately should participate in either lipid synthesis or glycogen synthesis. So I'm not sure, like, if that also would lead to to your question, basically, of whether it should affect other tissues. The metabolism of sulfur dioxide itself may lead to like effect that we see in other tissues.
Okay. I'll just throw this out there. It's been about 45 years since I took a graduate course in biochemistry. So in terms of the Krebs cycle, is pyruvate is that utilized for ATP production?
Yes.
Yes. It's mainly for ATP production in the presence of oxygen, and in the absence of oxygen, it converts into lactic acid or lactate.
Okay. So in the tricarboxylic acid cycle, of which pyruvate is part, what is it metabolized to?
Acetyl-CoA.
Okay.
Enzyme.
Yeah. So acetyl-CoA is metabolized to acetate, right? Acetic acid.
Yes.
I'm drawing, and I'm not meaning to be too humorous here. When people ingest ethanol, right? What's the metabolite of ethanol? Is the first acetaldehyde. And what is acetaldehyde metabolized to?
Acetic acid.
And what's one of the adverse effects of chronic alcohol? Is liver, right? Toxicity, hepatocyte. Could that be linked to acetic acid? I don't know. But my point is, acetic acid is a very common metabolite with all kinds of things. Can there be too much pyruvate? There can be too much of anything. But if, once again, through a formulation, the sulfur dioxide can be delivered selectively to the pulmonary arteries, then the issue of pyruvate, maybe not so acute. The other thing you notice in this metabolic pathway, this pyruvate is released as part of the synthesis or the transformation of L-cysteine to sulfur dioxide. So if you could deliver a precursor that does not go through this pathway, maybe you don't have to worry about pyruvate. Does that make sense? So you have some alternative pathway. Hydrogen sulfide, boy, or thiosulfate, you could give as a nanoparticle, which then can be metabolite through its reductase to sulfur dioxide and use that approach. And you can avoid pyruvate. Interesting. Any other thoughts on this paper? Okay, well, I'm going to be looking for another paper for Thursday. I just got an email that the FDA has approved a new drug. Let me see if I can find the email. Hold on here just a moment. I'm going to stop the share. Does anyone else have anything to say about this paper? Okay, hold on just a moment. I'm going to stop the share. Okay, there we are. And I'm going to go to, well, minimize that. Get rid of that. I'm going to go to my, I'm not going to show you my emails, but let's see if I can find that post. Well, I can't seem to find it now, but I'll keep looking. And since this is a brand new drug, it'll be interesting to see what the, I'll take a look at it and see if it's something that's worthy of us to look at on Thursday. Any questions before we stop? All right, well, I'll see you the day after tomorrow. You all take care.
Thank you, Dr. Johnson.
Thank you.
Recording.